Welcome to Lunch with Docs HD Special Edition. This is Melissa Billiard, your host at HD Support and Care Network. Today, our special guest is Dr. Arik Johnson. He is the Staff Psychologist at the HDSA Center of Excellence at UCLA and the Fenton Coordinator of the Atypical Parkinsonism Disorders Clinic. While completing his internship in the Behavioral Medicine Clinic at UCLA is when he first joined the UCLA Department of Neurology while doing research on Huntington's disease. Today, he provides clinical services to patients and families living with Huntington's disease, Parkinson's disease, and atypical Parkinsonian disorders. Dr. Johnson also currently serves as the chair of the HDSA Board of Trustees, and he's been an active member of the HDSA Los Angeles chapter. He also has done some amazing collaborative work on the revision of understanding behaviors in Huntington's disease. HDSA has some incredible publications. I urge you to go to hdsa.org and go to their publications page. Most all of the publications are downloadable. Before we go ahead and introduce Dr. Johnson, I do want to thank PMD Alliance for providing this amazing platform for us, and Teva Pharmaceuticals for funding. So welcome, Dr. Johnson. Thank you for joining us today, and we will be talking about managing behaviors in HD, impulsivity, and disinhibition. Thank you so much. Take it away, Dr. Johnson.
Melissa, thank you so much for having me. And to those of you that are on here that I am not seeing, I will apologize to Melissa for being a complicated person to schedule. So thank you very much for working with me on this. And I'm so happy to actually be here and to talk to you guys today. As Melissa said, I'm a licensed clinical psychologist, and I work here at UCLA in our neurology clinic with both the HD clinic and our movement disorder clinic. So my focus is really on the behaviors that are associated with those different disorders. So I'll be talking about behaviors in Huntington's disease today, and I actually picked impulsivity and disinhibition to be the main focus, just because it's one that comes up in our clinic quite frequently. Let's see. Melissa, can I move the screen, or is that you going to be having
That would be me.
Okay, sorry. So, just wanted to give a couple disclaimers first. This is a informational presentation only. I'm not going to be giving you specific advice because there's a lot of information you need to know about a unique case before you make any kind of recommendations. Note that any recommendations are just general guidelines, and if you think something is applicable to you or your case, I really strongly encourage you to talk to your doctor, whether it's a neurologist or another healthcare provider, about anything that you think is something that would be useful for you today after this presentation. Next slide, please. Basically, the objectives are as listed. I want to talk a little bit about Huntington's, but primarily the behavioral aspects associated with HD. I want to give some more specific information about impulsivity and disinhibition. And lastly, to give some practical recommendations that could be helpful in addressing some of those behavioral changes due to the disease. Next slide. This is not news to any of you, I'm sure, on the slide or on the on this meeting. However, if you are new, I would encourage you to get some additional information about an HD 101 general overview. We know it's a neurodegenerative disease. It's hereditary. It's caused by the expansion in the Huntington's disease, the Huntington's gene, excuse me. People who have HD, who have that gene expansion, generally show symptoms in their mid-30s to 40s. However, there is a lot of variability, which is one of the things we know about HD in general, but that also applies to when people begin to show symptoms. Symptoms will get worse over time. That's what we mean when we talk about being a neurodegenerative condition. Things will change, they will get worse over time. And knowing that it'll change, we don't know how those symptoms are going to change or develop. We don't know at what rate, we don't know what specific constellation will be there, or when an individual will die from a disease. This is one of the big things that we deal with in treating Huntington's, is there's so much variability between patients, even within families. So we have to make sure that we look at each case as a unique presentation. Melissa, if you just want to click through till all three circles show up there. We talk about, yeah, sorry, I've got a lot of animation in here that I should have just taken out. So didn't realize you were going to have to be there just clicking the mouse all day.
Animation is good.
We know that Huntington's presents with a triad of symptoms. These are the main symptoms we see. There's the motor or movement symptoms. This is chorea. This is also the impact on voluntary types of movements. And then there's the behavioral components. And I'm going to include both psychiatric and cognitive features in this term behavioral. Really, it's how a person thinks and mood and personality features. So that's what we'll talk about a little bit more. Next slide. This is something we have learned clinically and more through research, is that people who are living with Huntington's disease have told us that it is those behavioral components, right? The way that a person thinks or the mood and affect symptoms of HD that present earlier than the motor symptoms. And in fact, these can oftentimes have a greater impact on the individual. Behavioral symptoms can impact a person early on in the disease, sometimes years before motor symptoms even begin to develop. Melissa, if you don't mind clicking. This is going to have an impact on a person in their relationships at home. This can have an impact on a person's ability to function at work. The behavioral symptoms are often one of the main reasons that people look at placement outside the home, and really why so many people apply for disability. It's harder to maintain your job. It's harder to do the work that you've been doing as some of these behavioral, both the cognitive and psychiatric symptoms are developing. I said this earlier, research hasn't begun. Research does support this report. You know, this was something we heard from patients and families way before the studies like PREDICT, PHAROS, Cohort, some of the big observational studies actually gave us evidence that this was occurring. There's a number of factors that can impact the behavioral aspects of Huntington's disease. I just broke down 4 of them, and these include changes in the brain. Those are the physiological changes due to the disease itself. Environmental factors such as, you know, what kind of house do you live in? Is it crazy and loud all the time, or is it calm and quiet? Other environmental factors include the city that you're in, or if you're not in the city. There's all those different things that are kind of outside the individuals fall into the environmental group. Individual factors, include things like a person's personality, their temperament, their ability to handle stress, things that are unique to each and every person. While we are here today talking about Huntington's disease impact on behaviors, you know, what the person brings to the table just because of who they are also is going to impact those behavioral symptoms as well. And then lastly, other health factors. This is something I point out a lot because sometimes people come into our clinic, actually, not even sometimes, it happens a little bit more than you might think, where people come in and say, wow, you know, mom or dad really changed like overnight. Like all of a sudden they're super agitated or they're angry all the time. And oftentimes we can say, you know, did you go to the doctor and have them check to see if they maybe have a UTI or a bladder infection? Because sometimes these other health conditions, like another medical cause, can actually lead to changes in that behavioral presentation. Why I like to talk about behaviors is because behavioral symptoms of HD can actually be treated. I think it's important to remember that and to think about that. It's complicated because of this overlap between the cognitive or the thought processes and psychiatric features of the disease. So treating those behavioral symptoms can get complicated. Sorry, Melissa, that was the next click. Click again. Yeah, that's all good. Thank you again. If you could click one more time. The way that we treat the behavioral symptoms of Huntington's disease is the same as we treat all symptoms of Huntington's disease. We are not treating the disease itself. We are treating the behaviors. We're treating the symptoms that are presenting. So that's based on what a person is experiencing. We want to see less of it. Oh, that's okay. Actually, stay on that slide. And Melissa and I were talking about this a little earlier about some of the issues with behavior in HD. As you can see, this is just a kind of the summary list of things, and that's a pretty extensive list. Not everyone who's living with Huntington's disease is going to experience every single one of these behavioral symptoms. However, these are some of the more common ones. The left-hand column is actually more of the psychiatric symptoms, right? Depressed mood, anxiety or worry. Apathy is that inability to get started. Anger and irritability. And then psychosis. Psychosis being hallucinations or delusions, some of the bigger but more rare behavioral features we see in HD. The right-hand column, organization, learning, memory, perception, and unawareness and perseveration, since I'm reading them to you guys, sorry. Those are more of the cognitive issues with Huntington's disease. Those are things that impact a person's thinking. And when people are experiencing deficits in those things, it makes it harder to do things like be with your family members, right? If you're trying to like get ready for the day and you know you've got to get 2 kids dressed and out the door and be in 2 different places at certain times, organizing all that information can become overwhelming, especially when your thinking ability has been impacted. So just putting this out there so you see what some of the common behavioral issues are in Huntington's disease, knowing that we could have many different conversations about it, but today we're going to talk specifically about impulsivity and disinhibition. Impulsivity. This is, we define it as a tendency to act on a whim. It's just, you kind of think and you just do. Like it's an action that occurs before any sort of corrective thought takes place. These kinds of things will happen really without a whole lot of forethought, meaning that it's not like a person plans what to do. Melissa, if you want to click the next 3 bullet there. A lot of times impulsivity happens it's seemingly without a lot of thought, right? You don't really think, oh, what could happen if I do this? Or, you know, the last time that this occurred, you know, people reacted this way. So people don't really have a guard to this type of action. So impulsivity happens like that. Disinhibition and impulsivity go together because disinhibition is a lack of restraint. It's a lack of an editor, basically, right? It's a disregard to what are maybe the social norms. You know, if I know that I should not go up to someone and say, hey, you know, you're bald, right? I'll use that example as I'm sitting here with a light shining on the top of my scalp. You don't necessarily want to do that in public, but a person who's disinhibited may actually just go up and say that to someone they've never met before, right? I said this before, it's kind of like having an impaired editor, right? You might think a thought and your brain should kick into gear and say, hey, you know, you shouldn't run up to that stranger and say. However, if you are dealing with disinhibition, that editor's not there. You don't censor that. There's oftentimes a poor risk assessment associated with disinhibition. A case that we had in clinic was a person who was living with HD was in the car with their kids. They were going somewhere and the person got upset and just opened the car door and jumped out while in traffic, while the car was actually still moving. There was not a lot of forethought. There wasn't an assessment of, gosh, what could go wrong if I do this in this moment? Because the thought is there, that impulsive nature of action, and the disinhibition, which doesn't control that thought or modulate that thought. You see the person doing what we call acting without thinking, right? The person who was in the driver's seat, like, what in the world are you doing? The person who was jumping out of the car, that's just what was their way of getting out of it. Melissa, if you want to click ahead, there's 3 bullet points that should come up on that slide. You know, I talked very briefly before about some of the things that can contribute to behavioral changes. And the first was the brain changes themselves. One of the things that we know that contributes to impulsivity and disinhibition is this green arrow that you might see on the screen. It's connecting that thing that looks like a curled up shrimp to the front of the brain. This is the connection, but we call it the frontal striatal connection. It connects the frontal lobes, the front part of the brain, with the striatum, which is that little shrimpy looking thing. Which includes an area called the caudate nucleus, which is one of the areas that's most impacted by the changes in the brain due to Huntington's. That relationship, those green arrows, get compromised. So when there is a lack of signal between those 2 areas, we see people engaging in these kinds of behaviors. The frontal cortex, that front part of the brain, the green part that's shaded in at the top, that's also what we call the it's kind of like the boss of the brain. It's responsible for what we call executive functioning, which is decision making, organization, being able to prioritize, things like that. So when we have a breakdown between the caudate and that frontal lobe area, that's where we begin to see these types of symptoms present.
Hey, Eric, can I ask you a quick question? I don't mean to interrupt, but this is so interesting to me. What actually happens in the brain with this caudate nucleus and the proteins and all that? Can you give us kind of an idea of what is actually happening and why this happens?
Yes, I'm going to give you the really simple answer because there are slightly different impacts in different types of cells. But what happens because of that expanded HD gene, right? The mutant gene that someone who's got Huntington's disease knows they've got 40 or more repeats of. What it does is it creates a mutant protein that doesn't do what it's supposed to do. So that protein actually starts to clump up in cells, which actually causes the cells to die. So we'll start to see cell death and structural deterioration in those areas of the brain. So for example, the caudate, that shrimpy looking thing, as that part of the brain serves as a gate of sorts for neuronal impulses, which are the transmissions through our nerves to different areas of the brain. As that area has cells start to break down and die, those messages get sent incorrectly. They don't get stopped from being sent, which talks about impulsivity and disinhibition. So it's the clumping of those proteins that leads to individual cell death, which leads to individual structural deterioration, which leads to the symptom presentation over time.
Is it like a plaque, like in Alzheimer's, or is it like a goo, or what? It just gums up.
Similar to a plaque, yeah. No, plaque in Alzheimer's is a clumping of a different kind of protein.
Right.
What we say in HD, it's an aggregate, which is basically, just those proteins are the wrong shape, which causes them to kind of clump together and stick together, which causes the cell to malfunction.
And is that the CAG in the DNA?
Correct. The CAG in the DNA, that's the mutant gene. And what happens in the way that DNA works, DNA goes through this process where it separates, it creates proteins. Because that DNA chain is a little bit too long, when it codes a protein, that protein comes out misshapen.
Okay, great. I'm sorry to sideline you, but I just
no worries. That's it.
I thought it was kind of interesting and informative. Go ahead.
It is, you know what, and it's a fascinating topic, and I hope I was able to answer that question. I'll also say, really good to get one of the basic science people in here, because they can talk about that in a different way than I do. So often mine is talking to a patient who I'm sitting with in clinic who's saying, yeah, that's great, Eric, but I'm really depressed. Let's talk about that instead. So, but those are some of the basic functional ways that we look at those changes in the brain.
All right.
Okay. So impulsivity is something that we oftentimes see present as what we call problematic behaviors or actions, right? Melissa, there's going to be 4 bullet points after that. Actually 5, excuse me. What are the kinds of problematic behaviors we might see? They're things that are going to lead a person to have to deal with situations that might be complicated by any number of different means, right? Sometimes a person will spend too much money, without thinking about it. God, we had a $400 budget this month. How come you spent $1,000, right? Sometimes we see it where a person who is living with Huntington's disease, when their loved one goes to work, they leave and just go out and head around town without necessarily having a plan or even necessarily the means to get where they think they might want to go or to get home. Sometimes that leads to a person driving who shouldn't be behind the wheel. And sometimes we see that present as substance use, right? A lot of times, and I say this working as a psychologist, we see people try to self-medicate for mood symptoms. I'm just so worked up all the time. I need to have 6 beers to calm down. Sometimes people smoke marijuana, smoke other drugs in an effort to try to balance out what they're experiencing. And sometimes when a person is impulsive or disinhibited, you see too much of that kind of behavior. The last thing is acting inappropriately. Look, I put a very generic statement right there at the end. That's walking up to the bald guy in public and commenting on it. Or sometimes those are acting out sexually in ways that are inappropriate, that are not normal, meaning, maybe touching someone inappropriately in public or a stranger, or, a lot of those things. They don't happen all that often, but those are some of the things that we can see as well. More commonly, impulsivity and disinhibition is seen in conjunction with that anger and irritability that I talked about before. A lot of times people will report it's like an out of the blue temper tantrum. Someone just flew into a rage. We'll see those things happen with little to no warning. You can oftentimes see a person who's engaged in that kind of behavior acting out, but then returning to their normal baseline fairly shortly afterwards. And this sometimes is done with little awareness, and even more problematic in relationships, it's sometimes done with a person showing little to no remorse, meaning, God, you just, you lost your temper and you yelled at me and the kids, but then you never said, I'm sorry. And then the person might say, God, I didn't even really realize that I did that. So this is where we see the kind of compounding issue that can happen with the brain changes related to Huntington's disease, with the cognitive behavioral things. You can see an impulsive blow up followed by a return to normal without any indication that the person even realizes they just did it. So how do we treat disinhibition and impulsivity? This is important to note, and I've got a little animation that's going to follow that, Melissa. Sorry. As this is a statement that I throw in there for our conversation today, but it really is true for treating all the symptoms of Huntington's disease. One size does not fit all. One intervention doesn't fit every single HD patient who walks through the door. And so if you work with someone who's an HD specialist, or if you work with a doctor who's just gotten to know your HD because they're in your community, they need to recognize that, this single recommendation that I read on the internet isn't necessarily the only thing. So when we talk about the types of tools that we can use to treat impulsivity and disinhibition, I just want you to keep in mind that these are general recommendations, and you need to understand the individual case to make something that's more specific. The next screen, Melissa, if you want to just click through all of the different animations there. All this is a list of antidepressant medications. One of the first lines of defense, one of the first treatment options that medical doctors will choose when treating disinhibition or impulsivity, they're going to use the class of medications that we call antidepressant meds. Why? Because it has an impact on the same area of the brain that will lead to impulsivity and disinhibition. So this is just 5 different common antidepressant meds that you've probably heard mentioned before for the treatment of depression, for the treatment of anxiety, for the treatment of anger and irritability. Antidepressant drugs it's not like taking a frying pan to the back of someone's head. It's not going to have a big wallop, but it's a kind of medication that can impact a lot of different things. So it's one of the first lines that we consider as a medical intervention for impulsivity and disinhibition. The next slide just lists some of the other agents that we'll consider. These might sound kind of familiar too. The neuroleptics, that's a class of medication that we use to treat the movement disorders of Huntington's disease. But these come from what were traditionally called the antipsychotic medications. So they are actually psychiatric medications that just happen to have the side effect of diminishing the extra movements seen in Huntington's disease. So remember when I was saying before with those 3 circles that everyone presents a different constellation of symptoms? If someone comes into clinic who's got impulsivity, but they also have motor symptoms, a doctor might want to consider one of these medications before prescribing something like tetrabenazine or Austedo and an SSRI. They might say, you know what, let me try Zyprexa because that should be able to address both of the issues that are coming up right now. So I just present these again for you to be able to talk to your doctors about, but know that there's medications that have different levels of impact. The last medication I have, this is an old school antidepressant that is oftentimes used in dealing with impulsivity as well as kind of obsessiveness and perseveration. So clomipirene is something that at least the medical doctors I work with here and in psychiatry will oftentimes use to treat some of those symptoms of Huntington's disease too. Again, these 2 pages were just a general list of medications. of course, that's a conversation to be had with your medical doctor. I want to talk now about some of the coping strategies. This is more what I do on a daily basis when I work with folks. When we talk about coming up with coping strategies, I want you to think about it as a problem-solving exercise. How do we do this? You want to identify what the problem is first and foremost. The problem here is, dad tends to spend money without thinking about it. Okay, we're talking about impulsivity. You want to gather information. You want to collect data if you can. You want to look for any possible causes of behavior. Going back to that list of the 4 things that can contribute to behaviors, things like the environment, things like personal factors, etc. You want to take a look to see if there's any identifiable triggers. Then you want to set a realistic goal. All right, a lot of people will come in and say, okay, he's got impulsivity. My goal is I want the impulsivity to go away. That might not be realistic, but if we can make the impulsivity less, whether it's through a medical intervention or it's through some of these behavioral interventions, that's actually a more realistic goal because we have a greater likelihood of reducing a symptom than making it go away. Lastly, we want to be flexible. If you try something and it doesn't work, we want to try something else. It's kind of the, if at first you don't succeed, try again. That's a mentality that we take in treating Huntington's all the time. We want to try the tools that we know, but then we have to recognize that each case is unique. Finally, we want to reassure all the parties who are involved in this situation. The people who are living with Huntington's disease, meaning the person who's diagnosed, and the people who are living with Huntington's disease, the people who are living with that individual. Melissa, if you click, you can skip that one. I just went through all that. Sorry, this was something I tried to consolidate from a previous presentation. I didn't take any of these things out. So first thing you want to do is assess whether the behavior is happening for a reason. Is there something that's happening that requires attention? These are the kinds of things that we can actually do something about if we can identify what those are. Melissa, if you want to click twice, we want to encourage people to look for possible triggers. Is there something that's leading the person to act out in a certain way? Let's say that mom is losing her temper. Well, she's losing her temper because she's watching CNN all day long. Okay, that's an identifiable trigger. Unfortunately, there isn't always something that is that concrete. So first we want to assess, is there something that's leading this to happen? And if not, then we got to think about it in a slightly different way. The next slide, if you want to just click through until everything comes up on the page, that would be great. Sometimes those triggers are things like what we call environmental triggers, things that are happening in the house. If it's a really loud house, if you've got, 5 kids, 8 dogs, a couple of random chickens running around in there, that can be disruptive just because there's a lot of stimuli in that space. There's a lot of noise. Things that people don't always recognize, but temperature, right? If a person who's living with HD is running hot and your air conditioner is broke down, that might lead to an increase in problematic behaviors. Sometimes the environmental trigger is another person, right? God, every time that she comes over, he gets really upset. Some of those personal factors that we talked about before, the other health issues, infections of any kind are common. Pain is something that is often under-evaluated and under-reported in Huntington's disease. So if someone's got a lot of chorea and they've been bumping into the door jamb every time they go through, their elbow might be hurting, but they're not able to say, oh yeah, it's because my elbow hurts. They might be acting out in a way that you're going, God, what's wrong with her? Why is she acting this way right now? A couple of other things that are fairly common that don't always get measured internally very well by a person living with Huntington's disease, whether they're hungry or thirsty, or if they need to use the bathroom. These are things that can impact behaviors too. I'm just going to add, I was just thinking that while we're talking about impulsivity and disinhibition, all of those triggers can lead to other problematic behaviors as well. So this is a kind of general guideline, even though I've got the specific behaviors up there on the top. This one is just a transitional slide. You can power through that. How do we want to do this when we treat impulsivity through behavioral interventions? One of the first things that I like to do and really want to focus on, if you want to go to the next slide, is you educate the family members and other caregivers on how to address and deal with outbursts. The first way of doing that, if you want to click, is what we call active listening. A lot of times in HD households, if someone is acting up, the family members or caregivers are kind of going into action mode. It's like, we got to stop this right now. Like, we got to take care of it, whatever it is. And what can end up happening in that situation is you don't actually let the person who's living with HD tell you what's going on, right? You're just saying, we've got to be out the door in 10 minutes if we want to get our doctor's appointment. In order to do that, I need to have A, B, and C happen. Sometimes the person in the caregiver role, or the person in the family member, is just saying, we just got to power through, and a point gets lost, or the point is missed. So I try to encourage people to do what we call active listening. Really let the person try to explain what it is, rather than just rapidly responding to whatever it is. This is not always easy, because a person with ADHD might not be able to put their feelings into words. It's sometimes hard to say. It's sometimes hard to organize those thoughts. Melissa, if you want to click once. It seems like you're upset, but you can't really tell me why you're upset. That can be difficult in Huntington's disease. If you can click again. Sometimes, if you can identify that something is bothering the individual, oh, Mom, I see that you've got CNN again on it. Mom, I see that you've got CNN on again. Is that what's upsetting you? Here, do you want me to go and shut it off? Sometimes if you're able to identify what is a common trigger, that allows you to ask and have the person confirm that's what's going on. A kind of generic recommendation is to just regularly sit down and talk about, how can we work together better? I'll tell people, how about we might call like a family meeting, right? Sit down every Sunday at 5 o'clock, right before you have dinner, and just say, let's talk about how things have been going this week. Do you feel like I've been listening to you when you've been dealing with whatever was bothering you? Do you think there's a way that I can respond to you that's better? Would you ever be willing to try this? Because when I'm busy and you tell me that you need to go to the bathroom, I might need a couple of minutes before I can help you. Sitting down and actively talking about how you talk to each other can sometimes improve the way that we talk to each other. Going on to the next slide, that was all about communication. That again applies not just to impulsivity and disinhibition, but applies to a lot of general behavioral issues with HD. First and foremost, whenever possible, try to identify and modify, or change, or avoid triggers whenever possible. Some of these triggers are easier to address than others. And Melissa, I think there's 4 of them that will come up there, yeah. So sometimes it is, when you're watching, CNN, God, every time you turn CNN on, Mom, you get pissed off. Let's not turn it on today. Or let's limit the amount of time you do it. Sometimes it's too much noise. Whenever the phone rings, a person jumps out of their chair and gets really agitated. Can we turn the volume down on the phone? Can we move it to another room? Sometimes it's when you go to a certain part of town. I tell anyone who comes to visit us at UCLA, anytime you drive to Westwood, it's going to be awful. It just never matters what time of day, it's always going to be awful. So you might not be able to avoid that part of town, but can you plan a way of making it better? You know what? Yeah, we're going to go see Arik at UCLA, but afterwards we're going to stop at Chick-fil-A for lunch. Okay, that offsets how awful it is driving into this area. Sometimes it's, again, that noisy family of 5 kids, 8 dogs, and any number of random chickens. It's just a lot of activity going on. Some triggers aren't very easy to change. I'm thinking of one case that I worked on where an HD patient was really upset by their oldest child. And their oldest kid was also the one who was providing the most care. So it was a really hard, it's not like that person could leave. It's not like they could leave the house because they had to be there to help their parent. So sometimes you can't change the trigger as easily as others. Sometimes it's world events. I think just in the field of psychology right now, we're noticing a greater impact on people in general from all the things that are going on in the world. And sometimes the trigger is just the fact that a person's living with HD and they're very aware of that fact. So these are things that we can't necessarily change, but are there ways that we can work with them better? Onto the next slide. A lot of times, this goes back to that communication strategy that I was talking about. We want to be able to try to change the way that we interact with each other. We want to look at, what do I expect from this person? Is my expectation realistic? And sometimes we want to look at what it is that we do in our roles in this family or in the household. If we are going to make changes, I always encourage people to try to do it gradually or in kind of this stepwise manner, because it's oftentimes easier for a person living with Huntington's to accept smaller stepwise changes than one big change all at once. You know, say for example that, you know, Dad, you've been having a lot of, you've just been running up the stairs without using the handle, so we're going to move you from your bedroom upstairs to the bedroom downstairs. You don't want to just have Dad go out for the afternoon and come home and all his stuff is in the new bedroom, because that might just freak him out. Instead, you might want to say, okay, we're gonna look at what's up here. Let's go look at the bedroom downstairs. Let's figure out what things we want to bring down and what things can stay up there. If you can break it down into smaller parts, it oftentimes makes it easier than one big change. Expectation. This is something that I alluded to before when I said, you know, maybe the goal of treatment isn't to make the behavior go away. Maybe it's just to make it less. Sometimes the biggest part of my job is to talk to people about maybe that expectation is unrealistic. So is there a way that we can manage it better? It's kind of hard. Even as I'm saying that out loud, I'm hearing it in my own head. I'm like, oh my God, but I don't want to change it because that's what it needs to do to be different and better. But sometimes we need to reevaluate. We really need to look at this and say, maybe my goal shouldn't be that you never leave the house at all, but maybe that you make sure to let me know whenever you're going to leave the house. It still makes me nervous that you're leaving, but at least now I know you're doing it. That's a modification in expectation, and it might lead to a more realistic outcome. Reviewing and restructuring whenever possible. It's something that we want to do when a person's living with Huntington's disease, because the disease will change over time. So if, you know, mom's responsibilities are doing the laundry, cleaning the kitchen, it just might become more difficult in time. So we might need to review that. Modifying the home environment whenever possible. Try to make things as comfortable as possible. Try to make things as quiet as possible. Try to make things as safe as possible. Removing potential weapons from the house. You know, again, with impulsivity and disinhibition, we want to talk about anger and irritability overlapping with that. If someone regularly loses their temper, it might be a good idea to have any guns in the house removed, or to make sure a gun is in the safe and ammo is somewhere else, or to do things that potentially limit the possibility of something bad happening. You know, it's just one of those things that it's kind of better safe than sorry. And I use that example just because it comes up a lot, and I'll touch on it in just a little bit too. But one of those things that we want to pay attention to is make things as safe as possible. Having emergency numbers near the phone, it sounds so old school. I know we don't have phones necessarily on the wall like back in the day with a notepad next to it. Have your emergency phone numbers programmed into your phone or into everyone's cell phones. And talk about plans. Talk about safety plans with your family, with your next door neighbor, with anyone else who might be involved. Next slide. And Melissa, I'm going to apologize. I just looked at the clock and I'm like, oh my God, I'm already totally over time. So you holler and let me know if that's going to be.
You're fine.
Okay, we're going to try to burn through these last few slides. When we are trying to work with someone to change these problematic behaviors, pick your battles. Ultimatums really aren't a super efficient way of getting things done. However, in some cases, it's what you got to do. So if you do find yourself in a situation where you have to confront someone or present an ultimatum, there's a couple of generic recommendations that can really be helpful. And this is not necessarily just in a confrontation stage, but try to keep these things in mind if you're ever having a complicated conversation with someone. Try to remain as calm as possible. Try to keep the tone of your voice consistent. Try not to raise the volume of your voice. All these things can lead to kind of a little bit additional fuel in the fire, if you will. If you are talking to a person with HD and you're trying to set new limits, you want to be as gentle and respectful as possible while still maintaining those boundaries that you're trying to set. That fourth point, I know I've been over here talking with my hands a whole lot. That's not a good thing to do if you're in a situation that's like a confrontation. You don't ever want to point your finger. This is one of the worst things you can do. I think it's why politicians do this thumb point thing. But if you're talking to someone, try to avoid doing any of these obvious signs of aggression, pointing or shaking a fist, standing up and like swelling up your shoulders. You want to try to remain as calm as possible, as neutral as possible. And this is an important point, not just for living with Huntington's, but this is anyone who's ever related to another human being. Try to respond selectively. You don't have to answer every single thing that has been said. Every single point that's made, you don't have to come back with a tit for tat thing. Looking at some of these other, this is just if you want to click through to get down to where it says depression and anxiety, this is just an illustration of how impulsivity and disinhibition impact and are impacted by other brain changes related to Huntington's disease. Things like judgment, right? Again, impulsivity and disinhibition go hand in hand with judgment. If you have poor judgment, you're more likely to act in a disinhibited way because that internal sensor, that internal judge is malfunctioning. Again, those executive functioning things, those frontal lobe parts that the brain controls, are going to impact how a person acts. And lastly, depression and anxiety, those are going to lead, if I'm really depressed, I might not care if I act in a certain way. If I'm really anxious, I might act super quickly just because I'm worried all the time. On to the next slide. This is a little bit more about the safety concerns. And I always want people to think about safety first. The disease itself isn't really going to cause a person to become dangerous, but a loss of that normal control, that regulation, that internal judgment can lead to some of the safety concerns we were talking about before. If you are in a situation where you feel like it's getting worse and that the person who's acting impulsively and is angry and is having an outburst won't be able to stop what they're doing, or you feel like the situation's escalating or getting worse, I encourage people all the time to think about these things. Get ready to get out of the situation, leave the house if necessary, or step into another room, call for assistance, whether it's a family member who doesn't live at the house who's got a good way of talking to the person, whether it's the next door neighbor. Calling the police. This is something, we talk a lot about in the HD community. It's like, oh my God, the police don't understand. I don't want them to get involved. That happened before and it was so horrible. If safety is a concern, you have to think about everyone involved, not just the person with Huntington's, but the other family members. Is it a mom who's caring for the dad who's got 2 young kids in the back room? You got to think about everyone who's involved. So sometimes making a very difficult decision, like calling the police, is what is recommended. The next slide touches on suicide in HD. We talk about that. Yeah, there it is. Sorry. We do talk about this a lot, and I think it's important to consider when we talk about impulsivity and disinhibition. Suicide does occur at a higher rate in the HD community than in the quote-unquote general or normal population. It is known that impulsivity, disinhibition, and anger are some of the features that lead to this higher risk. It makes it hard for professionals or even family members to assess and kind of measure if someone is feeling suicidal and predicting, okay, is this person someone who's at risk, or preventing those things from occurring. So we do know that it's a higher percentage in the HD community. I encourage people to talk about it whenever you suspect it. Talk to your loved ones, talk to your family members, talk to your care providers, talk to mental health professionals. It's something that people are oftentimes concerned about, but oftentimes don't discuss, just because it's a hard topic to talk about, and probably something that we could have a whole other conversation about too at some point, and be happy to do so. But I just want you to recognize that relationship to impulsivity and disinhibition. The last slide is my second to last slide. Thank you guys for putting up with me getting through this. Hope that you got some general overview about Huntington's and some generic behavioral aspects, but then specifically about impulsivity and disinhibition. Hopefully some of these interventions that we talked about today, you can see how they apply in this particular area, but also across all behavioral issues with Huntington's disease. With that, I want to thank you for listening to me go through all of this, and I want to turn it over to Melissa to say, if you've got some questions, if you want to open it up, I'm so happy to do so. Thank you for putting up with me like you did.
That was excellent. I do have a couple of questions. Let me check my chat.
The person living with HD, a trigger can be anything that elicits a reaction. When we're talking about behavioral concerns in Huntington's, it's sometimes like the example I shared of the patient whose adult child was a trigger. Just by being in the same room, that person with Huntington's got upset because the kid was there. Even though the kid was there to make dinner or to clean up the drink that the patient had spilled, just by being there, it's that thing that leads to a behavioral response. The trigger can be identifiable like a person, a sound at someone at the door, a room that's too hot, uncomfortable clothing. It can be, it's any sort of thing that can lead to a response. They can be any variety of things, right? It's not, I try to do kind of the thematic things like people, places. It can be times of day, right? Sometimes people just get agitated at about 3 in the afternoon because they woke up at 8 o'clock, they had lunch, and now they're kind of going into that little valley that people experience. That can be a trigger in itself. So it's really just anything that would potentially lead to a response.
Do you think maybe keeping a journal on some of these triggers might be a good idea, just to see what kind of pops up typically?
You know what? It's not a bad idea. Yeah, it's not a bad idea. I was just thinking it can be a lot of work though if there's nothing that's easily identifiable, right?
There's
like,
a lot of
yeah, or yeah, the list is now 3 pages long. In a case with a lot of triggers or a lot of identifiable triggers, we might actually just say, maybe it's the reaction system that is a little bit higher than it should be. So,
heightened personality traits and behavior.
And that's where some of those medical interventions can be helpful, the SSRIs or the neuroleptics. But it also is, it's always an opportunity for the other people to say, is there anything I can do differently that might have an impact on how that's working? The behavioral symptoms are what we've seen to show up earlier than the motor symptoms, right? Mm-hmm. Prodromal, the term you just used, is it's based on the fact that the diagnosis for Huntington's is still based on the presence of motor symptoms. Mm-hmm. However, we have a lot of people who know they carry the gene for years before they even show any sort of motor symptoms. So it's that time in between that we're calling prodromal. And that's where we tend to see psychiatric and cognitive or the behavioral symptoms show first.
And what if the person doesn't have motor symptoms?
At that time where there are behavioral symptoms present?
I've talked to several family that have said that their HD person never did have chorea or movement disorder.
Yep.
Part of it.
And that's where, with that 3-circle diagram, mm-hmm. while we do know that there are 3 main areas for symptoms, motor, cognitive, and psychiatric, people can experience a different amount of each one at different times. And yeah, there's absolutely some people who show predominantly psychiatric symptoms, but very little noticeable movement at all. It's not uncommon for people to have these very different presentations, right?
Another question that has come in before, not on this particular presentation, but I've had so many different interactions with people about suicide, and that's such a huge concern for caregivers and parents and people who are caregiving. But in my own case, my son always talks about it. He talks about it, and I talk to him about it. I don't say, oh, we're not going to talk about that. But it's something that, they talk about, and it's scary. What do you do when they're always talking about it?
Oh. My first recommendation is what you said you do. You actually do talk about it. It's a normal tendency for people to say, you know what, let's not talk about that right now because we're about to have dinner, or try to put it away. Talking about it is important because it allows you to have a better sense of a person's actual intent. Are you thinking about doing it today? No, I'm just thinking about it in general. When we work with people clinically, we're looking for intent, right? The intention to actually do it. Mm-hmm. We look for a means. Does the person have the tools to do this? Mm-hmm. And do they actually have a plan? So I would change that order a little bit. I would say intent, plan, and then means. Mm-hmm. Does this person really want to do it, or are they just saying, I don't like the way that my life is and it would be great to escape this? Mm-hmm. Sometimes that's the conversation, not the, I actually want to go out and do this today. Mm-hmm.
Yeah, that's usually what happens. He's just so miserable or in so much pain, and that's the first thing they think of when they know that there's nothing to be done about it. Right.
And it's hard to say that it's a very normal thing that I hear in this particular population. Yeah. And in some of the other groups that I work with too, is there's nothing that we can do about this. So why even bother? And I get it. There is nothing that we have right now that changes what a person is living with. But I will always make the argument is, can we make it even just a little bit better? And some people are open to that. It's like, all right, if we can figure out a way for this to be a little bit better, I'm happy to explore it. But some people are just not wanting to. It's a case by case basis.
Right.
But we always try to assess, how serious is the intent? Is there that plan? Are there the means? But then the other part of this, Melissa, that I want to address too is, we're talking about the person who's talking about suicide. What about the person who's being talked to?
Exactly. Yeah. It's hard.
This is going to sound so pat and cliche, but I mean it with all sincerity. Having someone to talk to yourself, whether it's a really close friend or in an ideal world where we all go to therapy and we all think it's a totally great, normal thing.
Teletherapy.
Yeah, exactly. Yeah. No, there's new resources now that are becoming available that make it easier to do that, because a lot of people, especially folks in the HD community, say, yeah, therapy would be great, but I can't leave my house.
Exactly.
So there are resources out there now like telehealth, where you can actually work with someone who's available when your loved one goes to sleep or before they get up in the morning. And there's ways to do it. Taking care of yourself in it. Sometimes being able to say, God, I'm really feeling a little overwhelmed by having that conversation today. Is there something I can do to lessen the impact that I'm feeling right now? Is there someone I can talk to? Is there an activity I can engage in? You gotta make sure you're taking care of yourself in that too. And I know I say that a million times a day, and it sounds so generic, but I mean it with all sincerity. Taking care of yourself is one of the most important things you can do as someone who loves someone with Huntington's.
Well, and for somebody who's kind of stuck in the home pretty much 24/7, I've made a garden out in the backyard and put in, 2 little fish pond containers out there. So I have little fish to talk to when I need to, which sounds so silly, but it's kind of my only refuge, And
I don't think it sounds silly at all. And I think it's important. What you just illustrated, you got to look at what are the very real barriers and boundaries and figure out how to work within them. Because I will always argue, even if you've got the most restrictive limits, is there a way that you can do something different? You might not be able to leave the house a whole lot, but if you've got those 2 little ponds in the back that you can go out and just looking at them gives you a little sense of joy or relief, that's a great way of finding something small that helps take care of you.
Something affordable.
Very real, very, very real limits got to be considered.
Or a soak in the tub, that'll do it too for a bit.
Right. An analogy that I like to use is someone who's the parent of a young child. just being able to go into the bathroom and lock the door for like 2 minutes just to breathe.
Exactly.
I actually have someone who said they go in the door, they sit on their floor with their back against the tub and put their feet against the door so that no one can open it. Finding those little ways.
Yeah, then I think one other thing that has given me some kind of peace is go to that Hallmark channel, you know,
right,
have a good cry and just release, you know.
Yeah, finding an outlet is really a great way.
Yep. Well, Dr. Johnson, thank you so much for bringing us this wonderful information today, and we'll go ahead and close it off. I'm going to put the video together and send it to you before we publish. And thank you to PMD Alliance and Teva Pharmaceuticals for providing this wonderful platform and format for us. And until we meet again, thank you, Dr. Johnson.
Hey, thank you again for having me, and look forward to talking to you all at some future time.
Hope we get to have you back on. Take care, everyone. See you next month.